Our client GR was referred to us by the ENT for trial therapy before surgery. They had a stroboscopy that revealed irritated supraglottic tissue and a small pathology in their posterior vocal fold area. The ENT does not suspect, though, that it is cancer. When we spoke to GR, they complained of a sore throat and having a raspy voice. We also noticed that they spoke at a low volume and had monotone speech. They have a couple of other health issues, most notably GERD, and they would like to avoid surgery. Our client is 58 years old and they own a restaurant. GR reported that their vocal discomfort severely impacts their ability to perform their tasks at work. They have a hard time speaking loud enough for their staff to hear them, especially when the restaurant is loud and busy. They reported to us that they no longer speak to customers at their restaurants because of their insecurities about their voice. And they also explained that they feel insecure about their expressiveness and would like to be more confident in that, especially when speaking to customers. They live with their partner and have two teenage children. The client GR was assigned male at birth and identifies as non-binary. They use they them pronouns, but they're not interested in receiving any sort of gender affirming treatment from us. They have never received therapy, voice therapy before, and they stated that they're happy with their current vocal presentation, excluding the medical difficulties. They reported that their voice problems started about a month ago and it was a gradual onset. When asked about their vocal effort for the week, they had a moderate level of vocal effort and they rated that their throat discomfort was severe. They have pretty good vocal hygiene. They drink a lot of water each day, but a few areas of concern include their caffeine intake and their alcohol intake. They also had a hearing screening, which came back normal. The client was given the VHI, where they reported a severe score of handicap. Their subscores in the functional, physical, and emotional areas, they reported severe barriers in all three domains. We also considered using a gender-based questionnaire, but since the client is not interested in receiving gender-affirming services from us, we chose to stick with a more medical-based one. Their auditory perceptual measures were taken using the CAPE-V tasks. Some areas to note here are that they were mild to moderately rough, moderately to severely breathy, and moderately quiet. It was also noted that they spoke in a monotone manner. Their acoustic measures show that they have above normal limit jitter, shimmer, and VTI measures. Their mean intensity is below normal limits. Their maximum intensity is below normal limits. And their glissando numbers are also below normal limits. Glissando measures are below normal limits. It's also important to note here that their average frequency was above normal limits, but that was not a concern for this client, so it's not something that we'll be addressing. These measures, though, are consistent with the suspected hypofunction. Their aerodynamic measures show that their peak flow is below normal limits. Their SPL measures are below normal limits. Subglottal pressures below normal limits. Below normal limits, their airflow is above normal limits, and their airway resistance is also below normal limits. Their phonation threshold pressure is above normal limits, and their maximum phonation time is below normal limits. These measures are also consistent with the suspected hypofunction, but at this point, we are interested in seeing if that hypofunction is due to a vocal fold paresis or if it's only caused by the pathology. GR had an EGG, which shows a smaller closed ratio. Their closed time was shorter in comparison to their open time, which is consistent with the breathiness we heard on the speech sample, as well as that hypofunction.
On the stroboscopy, we noticed that there was a pathology on the right vocal fold as well as irritated and red supraglottic tissue. The right vocal fold was unable to vibrate to its full amplitude, causing asymmetric phase symmetry and aperiodic periodicity. GR had a posterior glottal gap, and vocal folds were predominantly in the open phase. All these findings are consistent with a hypofunctional voice disorder as we suspected. Since our findings on the stroboscopy were consistent with hypofunction, we decided to conduct a laryngeal EMG to rule out any paralysis or paresis of the vocal folds. GR's muscles proved to be functional on the EMG, so we concluded that their presentation of hypofunction was due to them avoiding full closure because of discomfort. To summarize our clinical findings, GR presented with a small pathology on their posterior vocal fold region. Their voice was perceived as severely breathy and quiet, moderately low in volume, mildly strained, which led us to believe that they are hypofunctional. The stroboscopy confirmed that there is a pathology on their right vocal fold, and the aerodynamic measures were consistent with the hypofunctional disorder. After ruling out vocal fold paralysis with an EMG, we concluded that GR's presentation of a hypofunctional voice disorder is due to them purposefully not closing their vocal folds all the way due to discomfort. Due to GR's complaints of a sore throat and raspy voice and presentation of red, irritated supraglottic tissue and pathology on the right vocal fold, we originally thought that GR may have a papilloma. However, after reviewing his medical records and finding a previous diagnosis of GERD, we, along with the rest of his care team, ultimately diagnosed him with a contact granuloma. GERD is a common cause of contact granulomas because as the stomach acid repeatedly irritates the tissue, the body attempts to heal the tissue by forming these granulomas. Our first goal for GR is that they will rate their voice discomfort lower than a 3 on a 1 to 10 discomfort scale at the end of the day for 5 out of 7 days. One of their main complaints was throat discomfort, so it is very important for us to relieve that for them. Our second long-term goal is to increase the volume to a level that allows them to perform all tasks at work. It was mentioned in the case history that their limited volume is impairing their ability to do their job. Ideally, they will reach a point of having a mean intensity of 75 dB for 90 seconds in a loud room. Our last long-term goal for the client is to achieve a rating scale of 3 on a 1 to 5 monotone to expressive rating scale in 4 out of 5 given opportunities. Our client mentioned that they have been avoiding talking to customers because they do not like how monotone their voice sounds. So we want to build up from sentences to paragraphs to conversations and help them find an intonation that feels more comfortable for them.
The intervention options for GR begin with a referral to a gastroenterologist. This is to help manage their GERD symptoms before they begin therapy. Symptoms like regurgitation and difficulty swallowing are very common with GERD, and by managing these symptoms first, we can ensure that GR is beginning therapy safely. Next, we recommend resonant voice therapy. This is to minimize the client's reported vocal discomfort by producing a forward-focused resonance. This minimizes the impact on vocal folds and therefore reduces tension. We also recommend vocal health education to optimize vocal hygiene and vocal production to ensure that further damage does not occur. This also helps increase the client's self-efficacy so that after discharge, they're able to better manage their vocal symptoms. Once symptoms of GERD are managed, we recommend the client do vocal function exercises. These exercises will help the client project their voice at work by increasing volume and maximum phonation frequency. Diaphragmatic breathing will be introduced to increase the amount of air the client needs for breath support. If symptoms do not improve, we recommend a referral to the ENT, possibly for surgery. Generally, surgeries are not recommended for granulomas as there's a high rate of recurrence. If all other modes of therapy are exhausted, then surgery options will be explained with the client's hesitation to surgery in mind. We will not be using effort closure or push-pull therapy because this is used for strengthening the vocal folds, which could increase the risk of traumatic closure for this client. Our protocol is a 10-week program in accordance with GR's goals. Week 1, we have the rating scale, the vocal hygiene education, which includes education about the importance of water intake and vocal breaks. We also start the RVT exercises with hums, chants, and words. In weeks 2 to 5, we do the rating scale again, and then expand upon the RVT exercises by adding in short phrases, short sentences, and short spontaneous speech. In the last 4 weeks of therapy, we do the rating scale again. We expand even more on the RVT exercises, and then we introduce vocal function exercises. These exercises include maximum phonation time, pitch glides, and maximum phonation time at a high volume. For our first long-term goal, the client will rate throat discomfort lower than a 3 in 5 out of 7 days. The client rated themselves lower than a 7 by the 3rd session, so we moved on to the next goal, where the client rated themselves 5 out of 7 by the 7th week, so they reached the goal by the 7th week. And then the client rated themselves lower than a 3 by 6 out of 7 days by the final session. So this goal was met. Our second goal has to do with vocal function exercises, which is why there's shorter amount of sessions. We introduced vocal function exercises in the last 5 sessions. So this goal has to do with increasing volume to a level that allows them to perform all tasks at work. The client will maintain a mean intensity of 75 decibels for 30 seconds, then for 60 seconds, and then for 90 seconds. By the final session, the client achieved the goal of 90 seconds in 4 out of 5 opportunities. Our third goal is the client will achieve a clinician rating of 3 on a 1 to 5 monotone scale when saying sentences, when saying paragraphs, and in conversation. By the second session, the client was saying sentences in 4 out of 5 opportunities, so that goal was met. And then by the 7th session, the client was saying paragraphs in 4 out of 5 given opportunities. And by the last session, the client met their goal of a 3 in conversation in 4 out of 5 opportunities. So this goal was met as well.
The client's original CAPE-V measures align with their original complaints of a raspy voice and a contact granuloma. After completion of treatment, GR's voice was mildly breathy and quiet, and their roughness was judged to be normal. This indicates that the VFE and RVT successfully lowered their perceived breathiness and roughness and increased their volume. Managing their GERD through medication and diet also helped decrease GR's pain when voicing. Their raspy vocal quality is now resolved. The client had initial reports of having difficulty increasing their volume and complaints of raspiness and difficulty speaking loudly. The mean and max intensity improved greatly after therapy, falling within normal limits after vocal function exercises, allowing the client to increase their phonation time, breath support, and volume. The post data also reveals successful treatment, that the client's pitch was stabilized and turbulence was decreased, resulting in a less raspy voice. The shimmer value reveals that the client's amplitude also stabilized post-treatment, allowing the client to project their voice with an increased volume. The MPFR post data show that they are now able to access a wider range of pitches, having better vocal control and strength, and are able to speak more fluently with an ease in vocal production. GR's original complaint of a low volume and contact granuloma were consistent with their pre-treatment aerodynamic measures. Upon treatment, GR was able to increase their subglottal pressure, reduce their mean airflow, increase airway resistance, phonation
hold pressure, and maximum phonation time. All of these measures now fall within normal limits and indicate that the breathiness that contributed to GR's reduced volume is resolved. They now have the breath resort support to speak at a higher volume for longer periods of time, benefiting them in their workplace. GR presented as a 58-year-old assigned male at birth client and is now 6 months post-treatment, originally presenting with a hypofunctional voice caused by a contact granuloma on their right posterior vocal fold. The client reported having a high level of vocal discomfort and stated that they had a hard time being heard by customers and employees at work. They were judged to be moderately quiet and severely breathy. Their intonation was also judged to be monotone. After 10 sessions of intervention, including RVT, VFE, and vocal hygiene education, their phonotraumatic hypofunction due to a contact granuloma is resolved, and their voice is now judged to be within normal limits for volume and mildly breathy. Their maximum phonation time is within normal limits, and they reported decreased vocal discomfort and being heard better by staff while working at the restaurant, even when it is busy and loud. GR reports reduced monotone speech, allowing them to be more expressive when speaking to staff and customers, increasing their quality of life. The prognosis for GR is fair based on their commitment to home practice, decreased discomfort, and increased volume level. Due to the contact granuloma on their right posterior vocal fold, their symptoms may return. It is recommended for GR to continue the RVT and VFE exercises, including pitch glides, chants, and sentences, as home warm-up routine, and to contact the clinic with any questions or concerns. The client is advised to continue taking their GERD medication daily to prevent the need for future therapy and irritation. It is also recommended that if discomfort returns, GR contact their ENT regarding their contact granuloma and gastroenterologist as well as the clinic.